Okay, well, thank you everybody for joining us today. As Admiral Collins and Alicia noted, my name is Sarah Carrigan, and I'm a health communication specialist with CDC's Division of Reproductive Health and lead for the Hear Her campaign. Before I begin, I would like to acknowledge and honor the Creek and Cherokee Nations and their people on whose ancestral homelands I'm speaking from today. I'm also very grateful to my colleagues, Delight Satter, Janelle Palacios, who's joined us here today, all of you in this virtual room, and others who have helped to raise awareness of the needs of American Indian and Alaska Native mothers and the progress that they and you and we have made to improve care. I would also like to acknowledge the late Leslie Randall in advancing this awareness as well. There's still so much to be done, but I'm proud and humbled to be here with you today to share some of the work we are doing to hear and talk to American Indian and Alaska Native mothers, their loved ones, and communities. In this presentation, I will share more information about the Hear Her campaign and the resources we have produced to serve American Indian and Alaska Native communities. As Rear Admiral Collins noted, although deaths related to pregnancy are rare, most are preventable. We lose too many American Indian and Alaska Native mothers each year from complications related to pregnancy. American Indian and Alaska Native women are 2 times more likely to die of pregnancy-related causes than white women. This is unacceptable. I am here with you today, humbly as an ally, to help improve outcomes for American Indian and Alaska Native mothers. I want to acknowledge the trauma and systemic barriers that are linked to the disproportionately high maternal and infant deaths that many tribal communities experience. American Indians and Alaska Natives' maternal health is impacted by the ongoing and historical trauma of systemic racism, colonization, genocide, forced migration, reproductive coercion, and cultural erasure. These factors have led to systemic barriers to care, including higher rates of poverty and long distance to quality health services. Given the disparities that American Indian and Alaska Native people and communities experience, it is a priority for us to reach tribal communities and urban Indian communities with these resources. Despite these challenges, American Indian and Alaska Native people continue to be resilient and thrive. Many American Indian and Alaska Native people draw strength from culture and tradition. Their resilience is built through culture, spirituality, shared values, and a strong sense of identity. Culture serves as a protective factor in the health and well-being of American Indian and Alaska Native people. We honor the lives of those who have passed on and work to prevent future losses. At CDC, we are working to better understand the causes of pregnancy-related deaths and to apply that data to action. Data from CDC surveillance systems and fieldwork help to inform the development of the Hear Her campaign. As many of you are aware, in August of 2020, we launched the Hear Her campaign to raise awareness of potentially life-threatening warning signs during and after pregnancy and to improve communication between healthcare providers and their patients. It is a priority for us to reach tribal and urban Indian communities with these resources. In 2021, the Office of Minority Health provided funding to develop a segment of the Hear Her campaign specifically to reach American Indian and Alaska Native women and communities. With that funding, we've been working with CDC Foundation, Market Vision, which is the creative agency, Gray and Gray, a Native-owned and serving marketing agency, and the National Indian Health Board to develop this segment. CDC has worked to include the voices and perspectives of American Indian and Alaska Native people throughout the development of the campaign and will continue to do so throughout implementation of the campaign. We're grateful to all of the American Indian and Alaska Native people who have contributed their time, experiences, and expertise to this project. I did see some familiar names and faces from the people who have joined the Zoom call. So I want to thank everybody who has been joining these meetings, has joined the listening session, joined the discussion session, and have joined the conversations that we have had along the way, because your voices have helped to make these resources. Thank you. Now I'm excited to preview the materials we've produced. As I mentioned, our team has worked to include many American Indian perspectives, voices, and creative talents in these materials. These videos include discussion of pregnancy-related complication and harmful experiences with healthcare providers that may be difficult to hear. I know coming into this webinar that you're likely aware of that, but I do just want to note that as you watch these videos, they can be difficult to hear. So please take the space that you need. Please go off camera or take a break if you need to, or message if we need to stop at any point. I encourage all of you to connect with any support that you may need. Now here is our PSA.
The circle of life begins with the birth of a child, and that journey begins with pregnancy. People who are pregnant or who have had a baby know their bodies and know when something does not feel right. When they speak, we must listen. Hear her. Learn more at cdc.gov/hearher/AIAN.
Storytelling is the center of this campaign. We were able to produce the stories of 5 American Indian women who experienced pregnancy-related complications. Here is Mona's story.
My name is Mona Nojakam, and I'm from Taos Pueblo, New Mexico. Being a mom is everything to me. It's such an important role. It's such a sacred role, especially as Native people, especially as Taos Pueblo people, as Potawatomi people, that it's our responsibility to teach our children who we are and how important that is, and that they're able to understand who they are and carry on those traditions and values and customs and cultures. We've had conversations for a long time and just kind of discussing what family could look like. That was just a really important piece to us, to be intentional about it and really create kind of that sacred space to invite a child and call them down from the stars, because that's kind of how we look at it, as a very sacred being whenever children are invited into our family and they want to come to our family. And that was really important to me, to try and incorporate those traditional birth practices, some traditional teachings into that, because that's definitely gotten lost. I decided to go with the midwifery route. I really seeked out the wisdom and experience of a doula, in that Taos Pueblo doula provided so much information to me that nobody else really knew. I had a normal pregnancy for the most part. It's really difficult to decipher what's normal in pregnancy and what's not, because you'll read lots of different things, and even just talking to folks will say, oh, that's normal, when maybe it necessarily isn't normal. At about 41 weeks, I noticed that I was experiencing extreme swelling that kind of happened very quickly in my legs, and I brought that up to my midwives, and they referred me for more testing. And I was also experiencing kind of a flutter in my chest. It was actually kind of an increased heart rate, and that's when I knew that I was experiencing symptoms of preeclampsia, and that I did have high blood pressure as well as protein in my urine. I felt that something wasn't right. They would need to induce me that night. I wasn't able to pursue the home birth like I had originally planned, and as things progressed, then my blood pressure went incredibly high. And so at that point, I was unable to even move at all, and I had to just be literally on the bed. I had an emergency C-section, which brought out my baby healthy, thankfully, but I continued to have preeclampsia postpartum. Just days after having my child, I continued to have high blood pressure. And even when I was sent home, I continued to have high blood pressure. So I didn't know how to navigate this, what I was supposed to do moving forward. And thankfully, I had my midwives that were still a part of my process. I had a kind of community of support. Otherwise, I don't know how I would have gotten through that. My husband was amazing. He's always incredibly supportive of me. And I really rely and lean on my in-laws a lot because we're really close to them. I'm so happy and thankful that I had my husband right beside me throughout this entire process to really help me think through what was happening, as well as be an advocate for me too. Trust yourself. You are the expert of yourself, of your body, of your experience. And because you're the expert, You have the ability and the knowledge to really advocate for yourself. And if somebody's not listening to you, then talking to somebody else and saying, this doesn't feel right, and understanding the power and the strength that you have, that you can advocate for yourself in order to get, the equitable care that you deserve and you should have.
Now I would like to share Treva's story. Before we start this video, I would like to note that Treva shares experiences with discrimination when her provider did not respect her cultural practices or listen to her concerns. This can be difficult to hear. I'm so grateful to her for sharing her experience, knowing that it could help other mothers to receive better care.
My name is Treva, Afraid of Lightning Craddock. My Lakota name is Makata Troampiwi. I'm an enrolled member of the Minikoju Lakota tribe of Cheyenne River, South Dakota. In our culture, being a mother is a great, great honor. When I first became a mother, I was actually a teen mother. I had excellent support because of my culture. My aunts, my mom, they were all supportive, excited. Culturally, there are practices that our grandmothers, mothers, and aunts teach young women when they're getting ready to have a baby. I started having issues in my pregnancy in my beginning of my second trimester. I had morning sickness every single day. They shouldn't even call it morning sickness. I could not keep food down, and I kept telling the doctor that something was wrong. This is how I know that he dismissed me from the beginning of prenatal care all the way up to birth. I kept telling him, something's not right. I don't feel okay. My OB knew that I wanted my placenta so that I was able to, bury it. Culturally, for us as women, it is a part of our body that was connected. It is the life source that was connected to our baby. And they let me know that there was nothing. I was angry and I cried. That night, I cried alone, holding my daughter, holding her. I was just crying. And I felt like nobody understood or cared. Throwing it away is very disrespectful. It's like sacred. So I go home with baby. I had an infection and I had to go back. They put me on an antibiotic and told me I couldn't nurse my baby. I felt like I had no connection to her. My mom's youngest sister comes back into the room and she's asking me if I'm okay. It would be really good for you to talk to a counselor because you're displaying signs of postpartum depression. It lasted until my daughter was about 9 or 10 months old. Some of the postpartum depression that I can remember were blaming myself. I couldn't even be a mother. I couldn't even be a Lakota mother. I started to have suicidal ideation of, why even be here if you can't do it right? It was just dark days. My second child, I had about a year later. I went into the second pregnancy with a mission. I was like a mama bear. I was in protective mode. The new doctor that I was working with not only heard me, he validated me. He let me know that he understood Lakota women's cultural practices when it came to packaging up the placenta. I felt relaxed and safe. I was really mindful and need to advocate myself. Choosing a safe primary care provider has been like at the top of my list. If you're uncomfortable, that first visit, change. You do not have to keep that person as your primary. If you feel that there is something wrong, talk to your aunt, your mom, your best friend, your nurse. Your nurse will tell you that it's okay to call whenever they feel that they need to call. Go in, have it checked. Never discount your gut feeling. Always talk to somebody about how you're feeling if you're feeling depressed, if you're feeling that you're not good enough, if you're feeling that you can't go through with the birth If you're having anxiety, if you're having fear, reach out to someone. Don't do it alone. Voice how you feel.
These stories are so powerful. I'd like to share one more story with you on our call today. This is Takela's story.
My name is Takela Lightfield, and I'm originally from South Dakota, enrolled member of the Cheyenne River Sioux Tribe of South Dakota, and I'm Minikoju Lakota. I have two daughters. The oldest is 6 years old, and the youngest is 15 months old. My second pregnancy ended up being horrible from week 5 until she was born. I was having some abdominal pain, and I initially didn't think that it was related to the pregnancy. Closer to my 3rd trimester, I had to go in weekly, and then it ended up being twice a week in the last few weeks before she was born, because I started swelling again, just like my first pregnancy, and then my blood pressure started increasing, and so then they diagnosed me with preeclampsia. I actually lost weight throughout my entire pregnancy. Because I was sick and vomiting every day, all day, from I was sick 5 weeks, but then until she was born. So I was swollen, I was tired, I had headaches nonstop, like around the clock. One Friday I went in and my blood pressure was just like really high. The next morning is when I had to start taking my own blood pressure readings, and it was high, so I had to call the nurse line, and they said, okay, you need to go in. I was like 32 weeks and 5 days, I think, and they were on deferment for anyone that was like earlier than like 36 weeks. And so I went to a hospital that I didn't want to go to. Every 15 minutes they were checking my blood pressure, and it just continued to go up and up and up. They did some lab work when I had just gotten there. A doctor came in and said, it was my liver enzyme levels were too high. They were trying to get me to 34 weeks, just because they said that the outcomes for a baby after 34 weeks are so much better. The next morning, the doctor came in and she said, your liver enzymes are increasing. It's no longer safe for you to be pregnant, so baby needs to come today, like this morning. And even though I kind of knew what was happening, it was still a shock. I didn't know that I was diagnosed with HELLP syndrome. It wasn't until after Charlie was born and they were like done with the surgery that the surgeon said something about HELLP syndrome. And I was like, is that what I have? HELLP syndrome it means that my liver was failing. You know, if they had waited any longer, or if I hadn't gone to the hospital or been like an active participant in my pregnancy, I could have died. You have to advocate for yourself in the medical systems. You see so many people when you're going to like different checkups and different, like the hospital, and then all this stuff that if I hadn't asked for certain things or asked certain questions, like that referral might not have gotten put in, and I might not have had that support. And I think it's important to share certain stories, like certain warning signs and symptoms, and then also know the warning signs and seek care immediately if you're experiencing them.
These stories are so moving. They're so powerful. I've heard them so many times, but it's still every time I hear them, they strike me. So I thank you for listening to these stories with me and with us today. I do want to note we were able to produce the stories of 2 more American Indian women who experienced pregnancy-related complications, Sarah and Vanessa. They shared their experiences with preeclampsia and postpartum depression, and the importance of sharing your concerns if something feels wrong and getting care immediately. For the sake of time, I will not play their stories now, but I encourage you to visit our website to watch those videos. I do also want to note that we were able to engage an American Indian photographer to capture photography of American Indian and Alaska Native people, helping us to meet another need for diversity and inclusion in public health materials. In addition to the video sharing these women's stories, we've produced educational materials to help raise awareness of the urgent maternal warning signs and improve communication between providers and patients. These materials are all housed on the Hear Her website, along with additional content and links to related resources. What you see on this slide is the urgent maternal warning signs poster, which helps to raise awareness of the symptoms that could indicate a life-threatening situation. In addition, we've produced conversation guides and palm cards for people who are pregnant and postpartum to help them to share symptoms they experience and raise their concerns with their healthcare provider. It can be really challenging to talk about pregnancy-related complications or to know when something is wrong. So we hope that these will be tools that will help people who are pregnant and postpartum to raise those concerns effectively. We also have a handout and palm card aimed to family, friends, and other support people. We know that it can be challenging to talk about complications related to pregnancy. Pregnancy and childbirth are a sacred time and a blessed and joyous time. So talking about these difficulties or challenges can be really hard, but it's really important for people to get the care they need when they need it. This tool can help facilitate those conversations to make sure that people who are pregnant or postpartum get the care that they need. Finally, and most importantly, we have materials designed for healthcare professionals. Healthcare professionals play a critical role in eliminating preventable maternal mortality. A critical part of the solution is to really hear women's concerns during and after pregnancy. The materials we have developed emphasize the importance of building a relationship with patients, supporting their cultural strengths, and ensuring that they feel safe sharing their needs and concerns. We also share information and resources on providing culturally appropriate care. Understanding and respecting the unique needs and cultural practices of each patient is an important part of building trust and providing medical care. In addition to the downloadable and print resources, we've produced a suite of shareable graphics and social media posts for partners to amplify the message and help get these resources to American Indian and Alaska Native communities. I encourage all of you to browse these resources that we have on the website and to see how you might help us to amplify these stories. These resources were launched 3 weeks ago on November 16. We are so grateful to be working with the National Indian Health Board on the development and implementation of this campaign. NIHB's Maternal and Child Health Team will share information on our plans to help build capacity for tribes, tribal organizations, and urban Indian organizations to implement this campaign later on this call. Thank you again for taking time to learn about these new resources and for the work that all of you do. I believe that we will have time for questions after, so now I will turn it over to my colleague, Janelle Palacios.
Thank you so much, Sarah. And I'm honored to get to introduce Janelle today. Dr. Janelle Palacios is a nurse midwife, researcher, lecturer, and storyteller, originally from the Flathead Indian Reservation located in Montana. Earlier in her career, Dr. Palacios worked with tribal nations and communities identifying the strengths of young parenting. Through story work, Dr. Palacios expanded our understanding of motherhood formation among young mothers. Dr. Palacios has served as the co-president of the Native Research Network. Her expertise in Indigenous maternal health has been recognized both regionally through a consultation work and nationally as she currently serves as a committee member on the Advisory Committee on Infant and Maternal Mortality under Health Resources and Services Administration. Additionally, she is co-chair of the Health Equity Work Group within this advisory committee. Through consultation work, Dr. Palacios has extended her content expertise to include access to healthcare services among rural Indigenous women, has served as a content expert for CDC's Hear Her campaign, and serves as an American Indian Alaskan Native content population expert consultant for the Association of Maternal and Child Health Programs, designing an anti-racist health equity promoting population research curriculum. In concert with her outside expertise, Dr. Palacios has been a midwife in the Bay Area for the past decade and is the chair of the Supporting Vaginal Birth Committee at her workplace. Currently, Dr. Palacios is an attending, teaching OBGYN residents while also mentoring residents on large database studies to support vaginal birth. Thank you so much for spending time with us today.
Thank you. Thank you. That was a wonderful introduction. I am standing or sitting actually at home, virtually meeting you through Zoom, and I am on ancestral Pomo and Miwok land who are still here. So this is just a map. You probably, a number of you have seen maps like this that can show you where you're standing upon whose indigenous lands. And it's not just for the continuous United States, it's a global map. And after this presentation, I can drop a link below. So when you're traveling, over the world, you can see who was originally there. I'm a nurse midwife and a storyteller, a researcher, and a consultant. And a lot of who I am career-wise comes back to my home community and who I was growing up in my community. I'm Salish and Kohutne, and I grew up on the Flathead Indian Reservation and lived there until I was about 16, and then moved to Western Washington, and then eventually to California. Sorry, next slide. So we're going to talk about the power of women and what has been missing in a lot of our clinical work, as well as like national experience. Next slide, please. So this is just a few photos of where I'm from in Montana, and I'm hoping to return. It's always wonderful to be back on land that your people are from, and I'm hoping to return later this year, which will be the first time in about 7 years. Next slide. All right. A master storyteller once wrote, "Storytelling is the most powerful communications tool we have." So we think in story. Story is encoded in how we make sense of the world, how we learn, how we express ourselves, how we put pieces together to understand something, how we connect with one another, how we share jokes, and how we nurture the relationships we have, how we gain perspective. That is through story. So I get to share with you my perspective on the Hear Her campaign as a story work communications tool that is culturally appropriate, that is designed in collaboration, in community with Native people. Next slide, please. Think about the word destroy. Do you know what it is? De-story. Destroy, de-story. You see, and restore. That's re-story. Do you know that only 2 things have been proven to help survivors of the Holocaust? Massage is one, telling their story is another. Being touched and touching, telling your story is touching. It sets you free. This is a wonderful quote just to demonstrate that sharing your story or sharing a community story it can be healing. It can restore healing to a community and to individuals and to family members. And it is also touching. It touches our heart. It touches our minds. It touches our soul. It touches us in a way that we change. We believe differently. We act differently. We practice differently. Story is healing. Next slide, please. So this little figure is adapted from Joanne Archibald, who is Indigenous from Western Vancouver, Canada area. And she uses story work. And she thinks about storytelling and how story impacts us through different levels. So there is the self. Next slide, please. So there is a story as told by them. So what we hear from the Hear Her campaign for the first time, women and Indigenous women were asked, what's your story? What happened to you? It was a shift in power. It's giving up power, not necessarily sharing it, which I think more importantly, I think Don Warren has said, it is the giving up of power. And so in asking Native women what happened, that is giving up power in terms of, well, I'm the clinician, I know what happened, I'm a researcher, I know the numbers. So giving up power and asking the source, what's your story? What happened? It's culturally congruent. A lot of us have experiences of connecting with our community, with our family, with our culture, doing storytelling. It centers women's voices. So again, it goes back to that giving up power, allowing women to really share their experience. They are the expert of their own experience, right? And for so many policies and practices and rules and laws that are in effect, women are not recognized as experts. And in this case, the CDC Hear Her campaign came to women and asked them, what happened? What's your story? It empowers women then once they get to share their story, once they get to express and touch upon that emotion, that thing that may have been hiding that they didn't want to really look at. Once they call it forward and really share something and talk about something that was traumatic, it can help them start to heal and start to process. So it empowers women to use their knowledge, it heals them, and for some people, it enables them to act, to do something, to change. Next slide. The next level from Joanne Archibald's work from the South, story as told from the South, is the family level. Next slide. And I loved that the Hear Her campaign was so unique in that it's calling upon the family. Again, drawing upon cultural practices. I don't know if CDC knew this, right? But it falls in line with women's roles and responsibilities and women's partnership within their family, right? It's not one-sided. Not men get to dominate and get to decide and determine what happens, but the unit together, it's in partnership. So when we have this campaign, it's increasing the ability for women to speak up, but it allows their partners and family members to learn that there are early maternal warning signs to look for. So it increases awareness among family members. It prompts family members to listen and to act. And as an end result, it can strengthen familial bonds because the family gets to demonstrate caretaking of their loved one. There is a wonderful anecdote I have of when a young boy in the Bay Area, he was about 5 years of age, he knew that his mother suffered from attacks of like seizures. So like seizures where she would collapse and be unresponsive. And at the young age of 5, he had been taught when that happens to call 911. So this little boy witnessed his mother in a seizure and he calls 911. And unfortunately, the 911 operator did not believe him and did not send anyone to come help. And it took a bit of time. Eventually, someone came to the house. But here was a family member, a 5-year-old, who recognized that his mom was in distress and needed help. And he did what he's supposed to do, given like limited ability to articulate. You know, think about a 5-year-old and their developmental, where they are developmentally, you know, being able to probably not argue with an adult who's telling him, you know, stop playing around, hang up the phone, you're wasting people's time. And he persisted and he was able to find someone who listened to him. But again, it goes back to allowing family members to be accountable in that they get to care for someone they love. They're accountable for the caring and love they have. Next slide, please. The next level Joanne talks about is the community, right? So we have the self, the family, the community. Now, what is the community's responsibility to women? Next slide. So again, this is what's great. I don't know if CDC knew that they were doing this, right? But again, it's fallen in line with Indigenous practices of looking at everyone involved. It is not just the Western view of looking at the woman and her infant, or the pregnant person and the fetus and the baby, right? It is not just putting all the burden on someone, on the individual, saying, oh, well, you are not eating, you're not eating well, you're not eating healthily, even though they might be in a food desert and not have access to, like, you know, low cost healthy foods. But because you're not eating well, you know, you are responsible 100% for your diabetes, not taking into account historical trauma, how it's affected our genes, how food sources have been limited, all those things, right? It's calling upon the whole family as a collective, the community as a collective, the community, the family, the individual, the dyad, the pregnant person and the infant together, the fetus. So it is drawn upon cultural practices in that it is calling all people in and saying, you need to learn these signs as well, because if someone in your family comes to you and they're not feeling well at work, at a community event, getting gas, getting food at a restaurant, at a library, out on a walk, you will be able to recognize. So it's holding the entire community also accountable, which is wonderful. So the community has a responsibility for being aware. The community has an active role and they are involved. And it can strengthen community ties about caring for that person, even though the larger community might not know this person, but the community as a whole now has responsibility for recognizing these symptoms and caring for this person rather than making assumptions. And I want to just point out, especially for communities with Native populations that share their space with non-Native people, like for example, my home reservation, most of the people who live on my reservation are non-Native. And having any sort of public service announcement that is going to hold the entire community accountable makes it so that there's no excuse for not having this information, this knowledge. Next slide, please. I want to just point out a few examples, and there are more, and I actually left out a very important one, which I will mention first. So Tiwa Women United has their own doula program, and I did not include them. It was an oversight on my side. I apologize for that, but I will put a link to each of these community organizations down below after I'm done. But these are really great examples of how birth workers within the community who have lived experience of being Indigenous people living in small communities or urban communities with their community, and knowing that there are cultural practices that they can institute that will call families back in to being a part of their culture and take care of them. So Alaska Native Birth Workers Community, I have a picture here of Elena Jacobs and Abra, both were in Yapuyik, and they do a number of things. They teach people how to become doulas, Indigenous doulas. So they do workshops teaching people, but they also are caring for the community because they do practice with story circles, getting pregnant people and postpartum people and their families involved in understanding healthcare, or understanding how to be involved in their culture, or introducing cultural ways of taking care, whether it's making something or using traditional herbs and plants and medicines to care for themselves. They also are building that workforce, right? So they're building the Indigenous, they're helping to build that Indigenous doula workforce, which is just like the Tiwa Women United. They're also building that Indigenous workforce, people from the community who have a lived experience, who have cultural know-how, who can then deliver probably the best care and caring for people in their community, their family. They also are there to educate the wider community, the people who are not, who are uneducated about culture and care and birth work, but also like statewide partners. So they do collaboration and education of these larger institutions to help gain access for the Native community to have better service, to have better engagement, to have better outcomes. Next slide, please. The next example, of course, is Nicole Gonzalez from Changing Women Initiative. If you don't know Nicole Gonzalez, you must be possibly have been, I don't know, under a rock or so, because Nicole Gonzalez has gone from local to national to international fame. She is like a famous Indigenous nurse midwife. She has, from day one, having finished her nurse midwifery school, she has worked every moment and creating her own home birth practice, women's clinic, and community-wide engagement services. So I again will share with you the work, Nicole Gonzalez's link to her website, and Nicole is Dine, and she's located in Albuquerque, New Mexico. She just recently moved to Albuquerque, New Mexico. And if you get a chance in your Albuquerque, I really highly recommend you eat the cupcakes. And there's like a few cupcake stores, but also then go to Nicole's place and go check it out for how to look at how to create space that is going to connect with the community and connect with your families. Next slide, please. The next example is Cami Goldhammer from Hummingbird Indigenous Family Services. Cami is all about breastfeeding and helping postpartum people in perinatal, the perinatal period as well. So the working with Cami, I've had a little bit of being able to get to know her through some conference work that she's done. But again, another wonderful example of how to take the westernized scientific knowledge and say, you know, actually, we have Indigenous knowledge systems that already knew that. And now we're going to re-deliver it in a way that is more accessible, more health literacy, to help individuals and families have more health literacy about these concepts. Because again, with our history, a lot of this was taken away from us. A lot of us may have had stories where breastfeeding was not a part of our life. I know from my mother, she was actually encouraged not to breastfeed by her Indian Health Service physician when she was a young mother. So all of us were pretty much bottle fed with formula. So it is taking back ownership, not just ownership, but just taking back that space that has been ours and saying, this is ours and this is how we're going to use it. And building that confidence, that cultural confidence in people and identity. It's also helping to build people's identity because they're coming collectively together and they're learning about their culture through these workshops, through all three of these organizations I've shared with you, the four, including Tiwa Women United. We're also learning about culture and community through that. Next slide, please. The last circle, and this is my circle, I added this, is nation. And next slide. So the Hear Her campaign put a national spotlight on certain populations of people, and Native American women were one of those people. And so now it is shining a spotlight saying, we have to be aware of Native women's experiences and making sure that they are being heard. This is phenomenal. I cannot compare this to anything else that has been done in the maternal child health world regarding putting a bright light, a spotlight, and then inviting Native people to come in and share their story and recognizing that it is the individual, the infant, the family structure, and now the community structure, right? So it is a calling into the nation. I don't know that they knew that that was intentional, but this is one way that I'm personally going to interpret it, that this is an opportunity where the nation as a whole can be aware that Native people are yet still here, and we still have some outcomes that we are trying to improve. Next slide, please. All right, so that was the Joanne Archbold Storywork framework. And now I'm gonna just talk a little bit about what providers specific can do. Next slide. So how can providers maximize their involvement? Next slide. So I wanna just give space knowing that whether it is people who have gone from Native communities who have gone off to college and who have gone through medical school or midwifery school or nursing school or public health school, that there is a shaping of their worldview as they are inundated within a westernized education system. And the way that people are mentored and expected to be successful is communicated in actions that these students learn. So students learn, especially in medical school, that they are the provider. And when they put on their white coat, there is automatically an elevated amount of respect that's already given to providers, to physicians. And so with that, and we can have our glasses are being fogged up with this way that we have been shaped for 4 to 7, 8, 12 years, depending on what your route is, through these westernized education systems, and then the training that goes with that. So we have to think about not just for the Indigenous people who go off on to do these things, but for the other people who are non-Indigenous, who have coming up through the pipeline of college and medical school or nursing school, midwifery school, dietitian, all of those things, that it can really shape who you are, and that you can come out with assumptions already. You can come out with implicit bias. So we have to be aware of those and call them out and be aware of them and work with them. So I do highly encourage people to do implicit bias training and to learn more about how to engage with that. The next thing is that when we go through this, this heavily laden process, that we put a lot of medical jargon into how we talk to people, and it's not accessible. So when we talk about HELP syndrome, like Takia was saying, that's not an accessible term. And so we have to really be mindful as providers. And if you're from an organization, health organization, think about how your providers, your clinicians can really connect to people and really talk at a different level that people are going to be able to access it, and use props, use diagrams, really, and then also ask for patients to talk back or teach back or explain to the provider if they understood something. That is going to be essential, because I believe a lot of the problems that we're having has to do with the health literacy barrier that providers are just not really showing up for. They have sometimes a busy schedule. You get 15 minutes and you have 25 patients, and the health literacy just kind of goes out the door because there's such a finite time to try to see patients, and not being able to really take the time to make sure that they understand, that the families understand. I would encourage all providers that if you're working with Indigenous populations and Native people, that really to be successful, not just as a clinician, but also successful for what it means to you and what you get out worthwhile wise, that you engage in the community, whether it is with a Native community or outside of a Native community, but it's actually participating and being in the community that is going to really help you as a clinician. When we talk about people who come from the outside, clinicians who come from the outside and they're working in Native communities, it's going to be really important that they learn about the community, that they show up, that they're visible, that they understand family connections. The longer they're there, the more they understand. They will see that even though they're taking care of this older auntie over here, there is this young daughter over here and this granddaughter over here. They get to see a tapestry of the family and then the community, the wider community, and see those connections. So I would recommend for clinicians to really consider how they can be in community, not just be physically in the community, but be engaged in the community and be learning with the community. Next slide, please. That I hope it is a little bit dense, it's a little bit a lot, but basically the message that I wanted to communicate was that I really want to applaud the CDC for the Hear Her campaign and the work they've done, in addition to the fact that when they contracted out asking for the photographer, asking for the advertising agency, asking for stories, that they went to the community and they found people who could do that, right? They didn't just have some photographer that, cuts them a nice rate, who's been working with them for 15 years. They actually went out and sought Indigenous people who could really edge in on that cultural experience and find what's going to be meaningful. They came to experts. I believe Nicole Gonzalez might be someone who also was interviewed and asked her perspective on how to reach families and how to engage providers. So thank you very much. for doing that. Thank you.